I will try, actually, after 3 marvelous presentations of my previous speakers, to summarize for you a little bit what we talked and how to apply it in your urological practice. And I know urologists, I'm too, like to operate, like to prescribe, but we need to treat the patients and sometimes the partner, and that's what I will try to explain to you today. I don't have any disclosure for this presentation, so let's make it easy. I will start with BPH, with Luts, and the burden and population. And last year, Lancet published a tremendous paper who show how global burden of BPH and Luts is in the whole world. And as you can see, as urologists, we have tremendous amount of work. Because in the world population, comparing to 2000 with 51 million patients suffering for Luts BPH, we increase in 2019 to 94 millions. Tremendous amount. So we don't need to be afraid of not having work as urologists, that's for sure. But what's important to realize is because we are educated always, yeah, BPH, Luts, older people. Look at this data. It shows you that actually the majority of patients with problems are between the 60 and the 75. Still age of sexual activity, but it's not going as you were 20 or 30, which is normal. But what you see on this side, okay, is that actually still majority of them are bothered by the complaints. And that's very important to realize. And as we know, there are a lot, this slide is not to show you all the data, but there are a lot of epidemiological studies who show to us that there is clear association between Luts and sexual dysfunction. And actually, about 50% of the male who have experienced Luts have sexual problems. And the majority of them have ED, between, let's say, 60 to 80%, and ejaculation problems, as you can see, between 40 to 60% of them. So it is tremendous amount. What we know more, the sexual activity, you can see here, the sexual activity per month decrease, and this is age effect. But if you put the Luts effect, you see that with severe the Luts, with less sexual activity and independent on age. It's happening in these groups of the higher prevalence of sexual dysfunction. So a clear correlation. And what's happening about the female? A lot of people know, we as urologists certainly know that Luts, male Luts and sexual dysfunction are there. Giovanni showed you the data as well. But about female, this is study published in the Journal of Sexual Medicine 2 years ago, 21, and you see with study with more than 1,000 patients with median age of 40. So what we see, young patients actually. Majority were not sexually active, and a lot of them, the male, again, 50% have ED, and almost 40%, look at the data here, almost 40% of the female had sexual dysfunction, and the female sexual dysfunction was mainly associated with nocturia. More than 2 times peeing at night, and this is not surprising. If you need to wake up at night few times, the next day you are tired. Think about yourself, what's happening when you are tired? You are irritating, you are less patient, you are tired, you want to sleep, you don't think about sexuality. So desire go down. Then the partner will have a reaction on that. So the study concludes that it's important to evaluate Luts patients on sexual dysfunction and vice versa, and independent of the age. Also when they are 18, we need to evaluate, and that's very important to realize. And other studies, and you see the reference, Gacci and Salonia and the Nonjo, publish other studies, and what you see, again, 46% of the female with Luts have sexual dysfunction, and most prevalent actually pain, but desire problem, arousal problem, and orgasmic problem. And mainly with female who have not overactive bladder, but overactive bladder symptoms. So it could be intestinal cystitis, it could be what they think recurrent UTIs, etc. They are suffering from female sexual dysfunction. And indeed, this is not something to discuss, good study, not study. The European Association of Urology have two guidelines on Luts in men and Luts in female, and both of them conclude two things: that in women with Luts, we need to evaluate sexological, gastrointestinal, and neurological symptoms as well. And Professor Bertocci showed you already that in case of male Luts, it's obligatory to take good history of the Luts and sexual history. So it's our obligation, even if we are just urologists. Okay? Now, let's say a few words on medical treatments. We will not go on all the medical treatments for Luts. You know them very well. Alpha blockers, look at the numbers, up to 30% sexual side effects, mainly the ejaculation one. The 5-alpha reductase inhibitors, between 2 to 20%, mainly desire and erectile dysfunction. About the anti-muscarine, we don't have good data, so I will not talk about percentage because the studies of our reports are only few case reports. If it's combination therapy, you see the numbers as well. But we do know that PDE5 inhibitors don't have sexual side effects, and hyaluronic acid also don't have side effects. So think about this possibility when you treat the patients. And indeed, EAU guidelines say clearly, all patients should be counseled about pharmacological treatment-related adverse event. This is our responsibility. Like we tell the patient before the URP, remember you will have retrograde ejaculation or unejaculation. It's also our obligation to talk about the sexual side effects and also to adapt the treatment to the patient that we want. And my title of the presentation is Sexological Approach. And I think that in all issues related to quality of life, and also Luts is quality of life, we give medication not because there is huge residual urine, only because of the complaints. We need to look at the biological aspect, the psychological, and the social. Even as urologists, you don't need to treat all the psychological aspects. We don't need to do it, but we need to take them into account, okay, and to collaborate with others. And I will show you what I mean with those aspects and how that related. So let's look how sex works. And I'm not going into detail. I'm sure you have, all of you, at least some experience, okay? But let's look what's happening normally. We have sexual function. We need it. Is biology. We have identity, how we feel, a male, a female, attractive, not attractive, less attractive, and we have our activity and our sexual relationship. And for sex, you don't need to be in fast relationship, and good relationship is not guaranteed for good sex life, and vice versa, but it's connected to each other. And imagine that we get Luts or any other condition, and you come to the doctors and they give you treatment. This will have impact on your sexual function. You saw the medication and you heard from Professor Bertocci also about surgery, and you heard from the first speaker about the impact for the female. So this will have impact on your sexual function, and that will influence your sexual identity. I don't know any man who come to my practice and say, I have ED, that he feel less confidence, that it feel less man. I say, what is the impact? I'm less man. Men reducing themselves to a penis level, sorry to say, but man is not only having good erection, but the impact is tremendous. And this will impact our sexual activity, because when there is problem, there is avoidance behavior. I will not give my partner a kiss because maybe she or he will think that I want something and I cannot do nothing. That's what males think. So they avoid. And there is no intimacy, not only sex, but also intimacy. And that will influence our sexual relationship. So think about it, again, the biopsychosocial aspects, okay? And how it works in the biopsychosocial aspect. There is tremendous correlation. The neurogenic factors, for example, increasing autonomic nerve activity, the adrenergic activities. There is the local factors, atherosclerosis, pelvic floor tension, pain. There are the treatments that will have impact. There are correlated factors, age, metabolic syndrome. You heard about testosterone, and I will show you in a moment more. And the Luts distress. And the Luts distress is mainly about nocturia and about fear of cancer or fear of surgery, and again, the sexual dysfunction. Those of things will impact the quality of life. And on the other side, as I told you, there is impact on self-esteem, on relationship, and both will impact the quality of life, and again, the sexual relationship and the sexual activity. So let's look on some biological factor. Giovanni told you about metabolic syndrome. The component of the metabolic syndrome will influence on the adrenergic activation. So we had less relaxed prostate, less relaxed corpora cavernosa, which is clear. We will have lower testosterone, and I will show you one of the reasons why. We will have atherosclerosis and inflammation. And you heard already from the beginning, inflammation correlates with those aspects, and I will show you also data. So from biological point of view, inflammation, atherosclerosis, nitric oxide reduction, sympathetic activity, and reduction of testosterone. These are biological aspects. And this study from Kirby and Chris Chappell, among others, show all the risk factors for Luts and ED. And you see all of them, almost all of them, are related to cardiovascular issues. But there are also two in blue, the insomnia, because of the nocturia, and the second is depression. These are psychological aspects. I will come to in a moment, okay? And metabolic syndrome, what is the most prevalent component of metabolic syndrome? The belly. And the belly fat, the visceral fat, is not just fat, is endocrinological active. Giovanni, endocrinologist, can tell you a lot about it, and I can talk a lot about it. And what's happening is the production there of all these factors and components. And you see again inflammation, and leptin will reduce the testosterone and will cause hypogonadism. And all of us know that testosterone is needed for sexual function. It's not obligatory to have, but it influences our behavior and it influences our function. How many of you know that testosterone is also important for females? Did you know that? Yes. Again, different level, different receptor sensitivity, but testosterone is very important part of female sexuality, because testosterone make us able to get sexual cues. We all, as urologists, know the patient that we castrate with the prostate cancer. They don't see sexual cue. The same goes for females. They don't see the advances of their partner. The desire go down. So this is important to realize. And another aspect is the pelvic floor. A lot of people think pelvic floor, lots complain, incontinence, we need to make the pelvic floor very strong. The pelvic floor is an emotional organ and is involving in our sexual function. Okay? Closure of the vagina, but also in the male sexual function, and I will show you in a moment. The ischio-cavernous and the bulbo-cavernous are involved in erection and ejaculation. To maintaining erection, we contract the bulbo-cavernosus. If we will relax those two muscles, we will postpone ejaculation. And there are evidence for physical therapy in premature ejaculation that delayed ejaculation. So these muscles are involved, not only in the male, but also in the female, because the ischio-cavernosus is directly connected to the clitoris. And the only purpose of the clitoris in nature is sexual pleasure. We can use the penis with the urethra to pee, but the clitoris, God gave us, nature gave us the female only for pleasure. And those muscles are connected there. The levator ani is also connected to orgasm, because see what's happened with the levator ani muscles during orgasm. Craziness of contraction and relaxation. And this is a feedback to the brain of experiencing orgasm. So the pelvic floor is also connected. So what's happening if the pelvic floor is tightened, very strong? People get complaints in the urine tract, in the sexual tract, the vagina, the penis erection, and the intestinal tract. Constipation, diarrhea, etc. What leads to pelvic floor hypertonia? Pre-existent disorder. Think about diarrhea by Crohn's disease, for example, or Luts complaint. If you have constantly urge and the feeling that you need to pee, every one of us contract the pelvic floor. Also trauma in the past, and also what we call psychological makeup. People who are perfectionists, who want everything on control, walking all day long with contracted pelvic floor. And, of course, overloaded. People who do bicycling, horse riding without relaxation will get overloaded pelvic floor. So we need to realize it. And if person have overloaded pelvic floor, hypertensive pelvic floor, they will get dyspareunia, they will get obstructive micturition with overactive bladder symptoms. They will have arousal disorder, as arousal disorder mean erectile dysfunction or less lubrication. They will get orgasmic pain, obstructive ejaculation, and even persistent genital arousal disorder. I don't know if you know this disorder, but it's dreadful. A lot of females suffer, some females suffer for it. Is tremendous problem. Okay, and indeed, EAU guidelines say that there is link between dysfunctional voiding and history of abuse, and abuse is certainly a factor of overloaded pelvic floor. And the ICS said that if we give them pelvic floor exercise or treatment, including relaxation at the right moments, they will be more satisfied with the treatment. Okay, so this is biology. Let's talk about psychology. Men with Luts have mental health problems. They score lower, certainly if they are older. And the older male have also social functioning decreasing. Think about not going to the theater, not going with the bus because they are afraid to lose urine or need to pee. Yeah? In men and women, and I don't show you exactly the studies, but I will show you in a moment, there is association between Luts and depression, anxiety, and somatization. And if you have anxious and have some depression, people exaggerate their experience of pain, Luts symptom, everything look worse. The end of the world. These are the patients that what we do in the clinic, they are not satisfied because they are afraid and they are depressed. And that's what we need to do something. So you need to look at those aspects because there is clearly association with inflammation. Again, Luts and depression are associated with inflammation. And that's very important to realize, again, with the intestinal cystitis, overactive bladder, Luts in general. Yeah? And you see from this research, psychiatry research indeed, that when they compare patient with Luts with a group of non-Luts, this is there, you see that there is odd ratio, higher risk of getting depression, anxiety and depression, tremendous. You see all of them with risk above 2, you see? And risk about 2 is significant risk. It's not 1.2 or 1.3. It's 2. It's double risk than other populations. Okay? And what we also see that the male have higher risk for developing depression or anxiety than a female, while depression appears in regular population more in female than male. And the younger age population have more risk. And these are the patients that are coming to our office and interested in sexuality. And depression is one of the most important risk factors for developing of erectile dysfunction and mainly low desire. In male is the first reason for developing low desire. Okay? Again, there is bidirectional relationship, and you see in a group of patients with overactive bladder, including interstitial cystitis, there is high prevalence of depression with different severity grade, and it's more prevalence in the young population, and the young population are the one who more frequently wish to have sexuality. So we need to be aware of this association between anxiety, depression, Luts, and we need combined treatment. What I'm trying to say, we as urologists not always need to treat the anxiety and depression. This is not our responsibility, but we need to signal it and to look at the sexual function because that will be influenced by those components and to do something with it. And I will tell you how. And don't forget the partner. When you involve the partner, there is more compliance with our treatment, but the partners suffer also from the Luts complaint. And what they suffer mainly from the night problem, inadequate sleep and waking at night, and the sexual empowerment. These are the most. And again, also disrupt family life, social activities, but the partners suffer as well. And again, the quality of life of the patient and the partner influencing each other. And you see it, terrible, unhappy, dissatisfied, the patient and the partner. And what they are saying again, sleep disturbance, fatigue, social life impact, embarrassment, fear of cancer, fear of surgery, and sexual life. Those are the impacts. All what I told you is saying in the research. So majority of the partners were affected by their partner Luts with consequence of sexual life. And as I told you, sleep and sexuality are the most concerns of the patients and the partners. And we need to do something about it. And remember, Luts will affect your self-esteem, fatigue, depression, anxiety, change the ability to enjoy, because if you are tired, you have less patience for other things, you just want to go to sleep. And then you go to sleep and you wake at night 2 or 3 times, and the partner too, so both going in a cycle of problems with each other, and the impact is also on their relationship. But remember also, I don't want to sound very old-fashioned, that female communicate different than male. Male just report, I have a problem, finished. Female more related. And that's very important to involve them, because the males don't talk about their problems. They're coming home, say, I'm tired, going to sleep. The females start, I have an awful day. And then you say, oh, leave me in peace. So they start to argue. And that will influence their sexuality, their intimacy, and all those things together. So from sexological point of view, again, the biopsychosocial, I told you social is the relationship, is the partner, is also the family sometimes. From biological point of view, the inflammation, the nitric oxide reduction, the testosterone, the pelvic floor, the fatigue. And from psychology, think about anxiety, fear, depression, self-esteem, self-confidence, and quality of life. And are all coming together in our office. Now, should we do something? Yes, we can. You don't need to be sexologists. You don't need to be psychologists or psychiatrists and to do everything. You just can have simple measurement, and there is something they call PLICIT. Someone of you heard about PLICIT? No. Okay. PLICIT is acronym used for permission, limited information, specific suggestion, and intensive therapy. And believe me that if you give the permission, you will solve the problem for 20% of the patient. Why? Because they will start to communicate with each other, with their partner, because they will know what is going on. If you give some information, you will solve another 20% of the problem. And if you do a suggestion, you reach 70% of the patient. You don't need to refer them to psychologists, sexologists, or whatsoever. You can solve it very easy because of communication and information. Because if you give information, some people will say, okay, now I know how it's come, and I don't need to do anything about it. Making a choice is also a solution sometimes. Or you think with simple suggestions to solve it. What I mean with that? If the patient comes to your office and you start with thinking about treatment, tell them people with Luts often experience sexual problems or often are in fears. Do you affected by that? It's already giving permission to talk about fear, depression, sexuality. Okay? Tell the people that it's confidence, it stays in the office, give them dignity, don't laugh at them because they are suffering and they are very embarrassed. Okay? Normalize. A lot of people have sexual problems. See the numbers. More than 50% of them will suffer. Are there any consequences for your partner? Then you can involve them and reassure, okay? You can say honestly, it's not my expertise, but I know that this is a problem, and if needed, I can refer you to a colleague around you who can deal with the sexuality or with the depression or whatsoever, okay? Then information, give education. Talk about the consequence of the condition. Take care that you have flyers of sheets or on your website. They will appreciate it as a doctor to care about them. So take care that you have information written. You don't have the time to explain everything. Give them written information, okay? Let them know that they are not alone. And that will have already tremendous impact because they will go home, open the flyer, start to read it, and may say to the partner, doesn't matter, male, female, both of them. And they will know, and then they look on solution. If they don't have solution, that's the time to give specific suggestion, okay? There is no straightforward. Each one of us have his own sexuality. Your sexuality is your fingerprint, okay? Each one of us. And it's not just coming from the sky. People expect the desire fall down from the sky. I'm becoming horny. I compare sex to food. How often you went to the dinner with your partner and both of you at the same time angry to eat? Not often. But you agreed that you are going to the dinner. Am I right? And the dinner was nice. And both of you eat. The same go with sex. Make an agreement. Talk about it, okay? Involve the partner. And if a patient said to me, yeah, we are very tired because I pee at night so much, so in the evening we are not in the mood for sex. And I'm telling you real example from practice. 2 medical doctors. And they are tired at night. So I said to them, according to what you told me, you don't have any children anymore at home. Am I right? Yes, they left, they studied, they're working, etc. And I said, you don't do on-call anymore. Am I right? Yes. What is the problem to have sex on Saturday afternoon? They didn't thought about it because they were used only to do it in the evening in the bed. And I always say to the patients, listen, like with food, if I will give you the same what you like to eat in Slovakia, schnitzel from Austria. If I will give you schnitzel the whole month, you don't want to eat schnitzel, am I right? After a month. Doesn't mean that you need to change the partner, the chicken. You can only serve the chicken in different way. That's also with sexuality. Don't think 5 minutes missionary position in the bedroom is the top of the world. No, there is kitchen, there is doggy style, there is variation. Let's make life more excited. Think about it too with your partner. And then, if it's not helping, adapt treatment to patient needs. Think, for example, am I going to give the patient a selective or non-selective alpha blocker? What I'm doing is I'm asking them, are you sexually active? And they say yes. Is ejaculation important for you? In early days, no one said yes. Really, I had partners who say, oh, the retrograde ejaculation is great because the bed stayed clean. Nowadays, I have patients who say, his ejaculation disappeared, and I like it so much. So I need to ask them. And I ask, do you care about your ejaculation? They say yes. So I will not give them selective, highly selective alpha blocker. I will give them non-selective, certainly if there is no hypertension and those risk factors, okay? And then PDE5 inhibitor, you heard from Giovanni. Excellent. We have so much data about the effectiveness of PDE5 inhibitors. Sildenafil, working great. It's a possibility for the erectile dysfunction, okay? And I told you about depression. This patient will go to the GP, and what they will get from the depression? SSRI. No. What SSRI, the most prevalent side effects? Anorgasmia and low desire. So we give them a medication who make them worse, okay? Did you know that you can give female also PDE5 inhibitors? I'm sure not. But I will tell you, it's off-label. But in 2008 already, Hamburger published this randomized study, sildenafil for female with SSRIs-induced sexual dysfunction. Significant improvement on all domains of sexual function. So also female can have PDE5 inhibitors. Remember that is a possibility. And reduce anxiety, reassure them. Not all patients go to surgery. There is no relationship between Luts and prostate cancer. There is no relationship between overactive bladder and cancer if you exclude cancer, of course. These are things that they need to be reassured and educate them. Penis in the vagina, evolutionary, is only for fertilization, reproduction. Sex is much more than that. It's not about performance, okay? It's not having only our direction. It's about having pleasure. And believe me, people who have pleasure in their sexuality continue very long to stay active. Not as they will be on the 20, but as later. It takes more time, request more foreplay. These are information that we can give them. I'm crazy about cars, so I compare it always to Porsche. You have a new Porsche, you push on the button, it starts immediately. Excellent noise. You have an old Porsche, like we become also old, you need to push on the button a few times and it will and then it starts. The same goes with sexuality. They need to have foreplay, they need to give time for each other. And if it's not helping all of this, then you can refer them to us, to penile prosthesis, to cognitive behavioral therapy, to gels, lubricants, hormones, injection. There are a lot of possibilities. I always say to my patient, I can guarantee you erection. Depend if you are willing to go all the process. Again, from PD5 till penile prosthesis. You can take care of it if they want and they wish and they have realistic expectation. Yeah? So, in summary, all patients who present with Luts, please ask them about sexual dysfunction. Even if you don't want to deal with it, reassure them, take, when you decide on treatment, the comorbidity, the risk factor, involve the partner, because when the partner is involved, the compliance is higher, the satisfaction is higher. Be aware that everything that we are doing related to Luts, except of some medication and some treatment, hyaluronic acid or PDE5 inhibitor, will have chance of sexual side effects. And be aware about anxiety and depression. The patients who are anxious or depressed are also for ourselves pain in the ass because they are not satisfied with our treatment. So if you want to have satisfied patient, address the issue, think about it. And remember that we need to work in a team. Sometimes you need to refer to the psychologist, and sometimes to the sexologist, and sometimes to the endocrinologist to take all the things into account. And the treatment that you choose depends on the symptoms, on the sexual activity, the age, and the wish of the couple, both of them. Thank you very much.